Oh. Bismillah, Assalamu alaikum everyone. I hope you're all doing well. For those of you who don't know me, my name is Mohammed Alfuwais. I'm a fourth year medical student, and inshallah for today I'll be going over Hemonc OSPE review as I did in CVP and so on. Firstly, I apologize for the beginning of this session and also for the last couple of days. I kept pushing it because I got sick, so that's why I couldn't do the session earlier than this. So anyways, we'll start. This is going to be exactly the same as CVP. I need you guys to be fully interactive. I would be asking you questions and I want you guys to tell me the answers, okay? And any important points I'll be explaining, obviously. So the first thing I'm going to go over is hematology. This will be all of, for example, the types of anemias, hemolytic, non-hemolytic, iron deficiency, megaloblastic, all these anemias. I'll be going over all the images, and then we'll go over oncology, which is lymphomas, leukemias, myelodysplastic diseases, and then micro, okay, at the very end. I won't be going over pharma. However, I'll be asking you some questions regarding treatment of some of the diseases that we'll see. Okay. So the first thing, which all of you should know, is CBCs. Now, CBCs, the things I want you guys to look at is obviously hemoglobin. You already know what's anemia, what's not. Obviously, it's going to be anemia if it's a low hemoglobin. Then these values, okay? These values I need you to look at. For microcytic or macrocytic, for the size of the RBC, I want you guys to look at the MCV, obviously. MCH is to see the what's it called, the amount of hemoglobin that's inside the cell. If it's low amount, if it's going to become hypochromic, or normochromic if it's normal. MCHC is the concentration, and it's very important in one specific type of anemia. And then RDW, which will look into the amount of the variation in the sizes. Okay, Tamam. Let's start. So what disease is shown in the images below? Look at the images, tell me what the disease is, then I'll ask specifics for this. Excellent, good. Iron deficiency anemia. Now, tell me from the CBC, let's go over it one by one. Actually, let's go over that later, inshallah. Tell me from this peripheral blood smear. Firstly, what do we classify this cell as? Microcytic, which means it's small, the MCV will be low, and hypochromic. Hypochromic because of the central area pallor. Excellent. What do we say this thing is? Pencil cell or elliptocyte, both works, okay? Good. Now, if you look into it, since we have different sizes, you can see that this cell is small, this cell is a bit bigger, this cell is much more bigger, and this thing as well. And then there's different shapes. You guys already identified this is a pencil cell or elliptocyte, and this is a round, like an RBC, a normal RBC, just it's round. So what do we say if it's different sizes? Excellent, good. Someone already said it. Anisocytosis for different sizes, poikilocytosis for different shapes. Excellent, good. Now, how about this over here, the other image? What do we call these two images? Koilonychia. Excellent, perfect. So this is koilonychia. Can you guys tell me other symptoms that we might see in iron deficiency anemia?
Pallor.
Good.
Fatigue, irritability.
Good. So these are all symptoms of anemia, general symptoms, a pallor, fatigue, you have palpitations, tachycardia, these things, which happens normally in anemias. I want you guys one specific symptom or general feature other than koilonychia that you can see in iron deficiency anemia. It's related to eating. Pica, that's it. Pica means that they have appetite to something that's it's not normal food. Okay, so they have, for example, they want to eat clay, they want to eat ice, they want to eat sand, things like this. These symptoms are very important when you're looking into a patient with iron deficiency anemia. Okay, so that's that. Now, I want you guys, for each of these lab values, I want you to tell me what happens to this. So hemoglobin, first of all, what happens to it? Low, excellent. MCV, low. MCH, also low. RDW, high. RDW is high because of the different sizes. Okay, good. How about reticulocyte count? It will be low because reticulocyte count is telling you that there's hemolysis, because in iron deficiency, there's no hemolysis. Okay, so this is low. The reticulocyte count would be high in hemolytic anemias. Okay, ferritin, low. Okay, TIBC, high. Perfect. The percent saturation for transferrin, low. Perfect. And serum iron, low. Perfect. Now, next question. What's the first thing to change in iron deficiency from all of these? Ferritin. Okay. The first thing to change, okay, if you have an iron deficiency, is the iron storage levels, which is ferritin. Okay. That's the first thing that changes. What's the second thing that changes? Perfect. It's all of these. Okay. The second thing will be all of the iron studies. Okay. Ferritin's number one. Then the second thing will be all of these things. Okay. Then the third thing will be this. Okay. All the changes that you can see in hemoglobin. And when you're treating it, okay, when you're treating iron deficiency anemia, it's going to be the direct opposite. Okay, so the first thing that will go up and fix is hemoglobin, MCV, MCH, then the percent saturation, TIBC, and all these things, then ferritin. Okay, so it's the opposite when you're treating it. So I want to make that very clear. Now, if you're looking into someone who has another type of microcytic hyperchromic anemia, let's just say someone has cancer, okay, no, don't need to specify what type of cancer, for a very long time, okay, suddenly they started to have symptoms of anemia, okay. Now, can you tell me what I'm trying to hint at? If they have, for example, something that's running for a very long time and they're having symptoms of anemia, the cancer is not a leukemia or a lymphoma. It's anemia of chronic disease. Okay. Now, can you tell me what's ferritin in anemia of chronic disease? Is it high or low? High. Perfect. Is TIBC high or low? Low. Perfect. You need to remember these two specifically for anemia of chronic disease. Another important thing is that early on in anemia of chronic disease, you'll have normochromic, normocytic anemia. Then later on, it develops into microcytic hypochromic. Now, can you tell me what's the one acute phase reactant that causes these changes in the iron studies? Hepcidin. Perfect. So hepcidin is the acute phase reactant. The acute phase reactants are normal proteins that get secreted from the liver. One of them is literally platelets, clotting factors, all these things. It gets secreted by the liver in the setting of inflammation, okay, because of IL-6 and some other cytokines. Hepcidin is one of these important things, okay? So what hepcidin does is it inhibits ferroportin. Ferroportin is responsible for releasing iron. Either this is from the enterocyte, where it gets absorbed, it gets transported into the blood, gets carried by transferrin, or in the hepatocytes, or in macrophages, okay? So iron itself will just be sequestered. It won't be released. It can't be used pretty much in the blood. It's just going to be stored inside the cells. So ferritin, that's why it will be high. However, everything else will be low because it's not going to be in the blood. Okay, that's why these are the changes that you can see in anemia of chronic disease. Okay, is that clear to you guys? Perfect. Now, can you tell me what are causes of iron deficiency anemia? Give me 3 causes or 2. Pregnancy, cool. Malnutrition. And what's the most common cause worldwide? It is ulcer, but the ulcer is more in the developed countries. Excellent. Hookworm is the most common cause. This is something that Dr. Ayhan wants you to know. A hookworm is something is the most common cause everywhere, especially in developing countries. However, developed countries, it's most likely going to be a peptic ulcer disease, GI ulcer, something like that. Okay, chronic bleeding, pretty much. Okay, perfect, guys. Yeah, no. A patient presents with the following. Hemoglobin is low, MCV is high, reticulocyte is low. What are you thinking of? And you can see this peripheral blood smear. Perfect. Megaloblastic anemia. Now, can you describe for me, and someone already said it, but what do we classify this blood cell or anemia as? It's macrocytic. Now, can you tell me what this cell is? This cell is a hypersegmented neutrophil. Okay. Now, in megaloblastic anemia, the two things that I need you guys to know, to see in the peripheral blood smear is firstly, the hypersegmented neutrophil. Once you see it, you already instantly think of it. Okay. It's instant. The other thing is macrocytes. Now, one way you can tell that this is macrocytic anemia is going to be through the MCV. Okay, MCV is high, and that's all you know. Reticulocyte obviously is low because it's not hemolytic anemia. Now, what further investigations do you guys need to get a diagnosis? Yes, to answer your question. Excellent. Folate and B12 levels, because the causes of what's it called? Megaloblastic anemia will be either folic acid deficiency or vitamin B12 deficiency. Now, the first test, obviously, to do, common sense, is folic acid and B12 levels. And you see, okay, if folate acid is low, okay, folic acid deficiency. If B12 is low, B12 deficiency. Easy. How about, let's just say that the values were borderline, very low. They weren't low, they weren't below the cutoff. What other two things you need? Perfect. Already you mentioned it. MMA and homocysteine. Okay. Now, can you tell me for folic acid deficiency, what's the change that happens with folate is low? Homocysteine, will it be high or normal or low? High. Perfect. MMA, will it be high or normal or low? It will be normal. Perfect. B12, what's the change? What's the difference between them? Both high for homocysteine, but how about MMA? High MMA. Perfect, guys. Okay, excellent. So folate, obviously, folic acid, let's start with that. Folate will be low, homocysteine will be high, and MMA is normal. Now, to explain these, homocysteine, to get converted into methionine, I believe, is it requires both B12 and folic acid. Okay, so it requires both of them. So that's why if you have deficiency in folic acid or B12, you will have high homocysteine. Okay, it doesn't matter. Now, the other one is MMA. MMA is methylmalonic acid. Methylmalonic acid is in the odd chain fatty acid, degradation pathway, where it goes from propionic acid to methylmalonic acid, and then lastly to succinyl-CoA. The last conversion, which is through MMA to succinyl-CoA, will require only B12. Okay, so that's why in B12 deficiency, MMA will be high. Okay, but in folic, it's not needed, so it's normal. Okay, now because of MMA, what specific symptom will B12 deficiency patient have? Excellent, perfect. Neurological symptoms or the specific disease is subacute combined degeneration of the spinal cord. Okay, SCD. Perfect. So this is very important. Why? Is because if you have a suspected patient with B12, you have to confirm the diagnosis of B12. You cannot start treating it with folic acid specifically. If you treat a B12 deficiency patient with folic acid without B12, this MMA will go even higher. Okay, so it will cause worsening neurological symptoms. Okay, so that's one concept to you guys. Now, can you tell me causes firstly of folic acid deficiency? Alcohol, perfect. Give me another one. Methotrexate, perfect. Another one is pregnancy because of DNA synthesis, perfect. Now, B12. Perfect. Okay, so you have something very important called pernicious anemia. Pernicious anemia is because of antibodies against either intrinsic factor or parietal cells in the GI tract. Okay, why will this lead to B12 deficiency? No absorption because of no intrinsic factor. Perfect. That's it. Where is B12 absorbed? Ileum. Where is folic acid absorbed? Jejunum. Perfect. Which one takes years to develop deficiency if it's nutritional? B12, and which one is more faster? Weeks to months. Folate. Perfect, guys. That's it for megaloblastic anemias and folic acid and B12. Now, can you tell me firstly what this whole thing is? Don't tell me specifically what the disease is or if it's normal, abnormal. Just what is this whole thing? Electrophoresis. Perfect. Now, in electrophoresis, what we need to look into is hemoglobin A, hemoglobin F, hemoglobin A2, and you have hemoglobin S. There's also other things like random ones that you need to look into, such as the presence of hemoglobin H, hemoglobin C, and some other random things. Okay. The most important ones for you guys to know is A, A2, F, and S. Okay. These are the most important values to look into. Now, why would you want to do electrophoresis? For what group of diseases? Hemoglobinopathy is perfect. So this includes thalassemias and sickle cell. Okay, perfect. Now, looking into this electrophoresis, is this normal, abnormal? If it's abnormal, tell me what disease are you thinking of? Normal, perfect. Okay. A is high, which is normal. Hemoglobin F or fetal hemoglobin is low, which means it's probably going to be an adult patient. So that's good. And A2 is below the cutoff of 3.5. Okay. So that's normal. It's good. Now we'll go over abnormal. So can you tell me from the peripheral blood smear first, what are you looking at? Perfect. So this is hypochromic microcytic anemia. This is beta thalassemia, specifically minor. And I'll tell you why specifically minor in a bit. But this is perfect. This is hypochromic microcytic anemia. It's beta thalassemia minor. What is this cell over here? What do we say that cell is? Target cell. Perfect. Good. So target cells are seen in many diseases. One of the important ones that we need to look into is beta thalassemia. Okay. It doesn't matter if it's major, minor, you'll see it in both. Okay. Now, can you tell me RDW, will it be high or low? Low. Perfect. Okay. RDW is low or normal, whatever. Okay. So it's not high. It's an important thing. Now, and you're looking into electrophoresis because obviously it's a hemoglobinopathy in beta thalassemia minor. Which value are you going to look into? A2. And what was the cutoff that I said? 3.5. Perfect. So hemoglobin A is high. Perfect. Hemoglobin F is low, which is good. A2 is above 3.5, and this is almost diagnostic, okay, of beta thalassemia minor. You see A2, that's very high, normal hemoglobin F. That's it. You can say that this patient has beta thalassemia minor, okay? In terms of signs and symptoms, it's not usually as symptomatic. They won't require blood transfusions. They might have mild anemia because of obviously microcytic hyperchromic anemia. Now for major, you're not gonna, it might be elevated in major, but you look into something else for major. Okay, and I'll show you that later. And also major is going to be very symptomatic. Okay, it's blood transfusion dependent. Without it, they can't live pretty much. Okay. So yeah, thalassemia minor is not transfusion dependent. It's usually asymptomatic. However, they will have or they might have of anemia. Okay, simple anemia. And that's pretty much it for mine. Now, can you guys tell me from these images, what are you thinking of? Okay. So someone already said thalassemia major. Okay, good. This is beta thalassemia major, most likely. We won't know until we confirm the diagnosis first. Can someone tell me what's on this first image? What is this feature? Okay, so you guys are describing it, depressed nasal bridge, but I need the key term, which is what it looks like. So there's two names that we can give it, either thalassemia facies or chipmunk face. Okay. Now, what's this image on X-ray? What are we looking at? Hair on end. Perfect. Good. Okay. And then what does this image indicate? Splenomegaly or hepatosplenomegaly. Perfect. I don't know if there's hepatomegaly, but there probably is. But splenomegaly for sure, because this is how the spleen grows whenever it's enlarged. It grows this way, diagonally. But anyways, now the most likely diagnosis is thalassemia. Okay. However, and I don't think you guys need to know this, but sickle cell disease, when it's very severe, can present with this when it's early on. However, you don't need to know this. No, if you see these things, think thalassemia. Okay. Now, why is it like this in thalassemia? Beta thalassemia major, specifically, is because of deletion of both beta chains, right? So you have beta null, okay? When this happens, there's something called ineffective erythropoiesis, where erythropoiesis itself won't be good anymore. So you'll start to see nucleated RBCs, it won't develop properly, you'll have severe anemia and things like that. Your body, to compensate for this thing, will start to do something called extramedullary erythropoiesis. What this means is that it's gonna expand to other tissues that's not usually responsible for erythropoiesis. For example, the spleen, for example, the liver, for example, bone marrow that's not supposed to be involved. For example, the face. So this one specifically is in the maxillary bone. This one is in the skull. It starts to go to these tissues. That's why you have enlargement of these bones, okay, and enlargement of these organs. That's why you have these features in beta thalassemia major. Is this clear to you guys? Perfect. Now, CBC was done. Can you tell me what we see in the peripheral blood smear? Can you tell me what the arrow is pointing at? And then, perfect. You guys already identified the target cells. This. It's a nucleated RBC. And as I mentioned, because of ineffective erythropoiesis, it starts to basically pump out nucleated RBCs, which is not normal. You're not supposed to see this at all in the case of normal blood smear. You're not supposed to see nucleated RBC. So you're thinking of beta thalassemia major now. What further investigations guys? How do we diagnose all hemoglobinopathies? Electrophoresis. Okay, good. So can you tell me from this electrophoresis, what will you see? High hemoglobin F. Good. So what's the diagnosis? Beta thalassemia major. Good. To answer your previous question, first of all, A2 is none because if you have beta null, for example, and then beta null, it won't be able to synthesize a normal beta chain, which is present in hemoglobin A. However, if you have something like beta minus or negative and then beta negative, which means it's just altered or mutated, it can still produce it. So that's why we say it's A2. Okay. This is, or I think it's hemoglobin F instead. But anyways, it's not present. Okay. It's beta null, beta null. So this means that's gonna not be good. Okay. But anyways, why is not a, let's just say an infant? Why, if we see hemoglobin F and this, we'll say this is beta thalassemia major. One other value that you can see here. Hemoglobin A. The presence of hemoglobin A tells you that this is not an infant, this is not someone very small, this is most likely an adult or elderly child. So that's why you can tell, okay, this is beta thalassemia major. Plus signs and symptoms, so you can say, okay, this is beta thalassemia major. Okay, let's move on. What disease is shown in this image below? Very small amounts, but for this patient, because signs and symptoms and everything, plus very high hemoglobin F, then they won't have it. And that's how you differentiate it. So anyways, this disease, good. You guys already identify it. These are sickle cells. Good. Now, how about these cells? Well, we already mentioned it millions of times now, but what do we call that? Target cells. Good. Now, is this a microcytic hypochromic anemia or is this a normocytic normochromic? Normal. Good. So sickle cell disease is a normocytic normochromic anemia, and it has hemolysis. So if we think of hemolytic anemias, what value are we going to be looking at? Reticulocytes. Okay, so the reticulocyte count will be high, okay, to compensate for the hemolysis. Good. Now, can you guys tell me which one is sickle cell disease, A or B? B. Perfect. Good. So, and what's this one? What's A? A is straight. Is straight symptomatic or no? Or carrier? Sickle cell trait or carrier is asymptomatic usually. Okay, he's just a carrier. Now, why is that so? It's because of hemoglobin S. If hemoglobin S is more than hemoglobin A, that's when the symptoms start to appear. Okay, because this is why it causes a sickling. Okay, whenever you have anything that favors a deoxyhemoglobin state, so for example, infection, hypoxia, whatever the case is, it causes it to start sickling. However, since you have higher amounts of hemoglobin A, this doesn't happen. Now, can you guys tell me what's the mutation that happens here? I mean, what amino acid changes do we see? Glutamic acid to valine. Perfect. Good job. Okay. And obviously this one, since it's very high and you don't see any hemoglobin A, this is going to be sickle cell disease. Good. Now, what disease is shown in this image? Okay. This is hemoglobin H. Okay. Now, this came in your LGD, so that's why I included things from your LGD to make sure I cover everything. Okay. But if you look into the regular values I've been talking about, it's all normal. Okay. Nothing's abnormal. However, if you look, he has a high hemoglobin H. Okay. Hemoglobin H, I don't think you need to know specifics, but just for your understanding, it's a form of alpha thalassemia. Okay, so you have beta thalassemia, alpha thalassemia. Alpha thalassemia is in the alpha chains. Okay, there's 4 types of alpha thalassemias. It goes from like mild to severe, basically in the order. The last part, or part 4, or type 4, sorry, is hemoglobin Bart's, which causes hydrops fetalis. It's not compatible with life. The third type is this hemoglobin H. Okay. You don't need to know any of that, just so you guys understand what this is. The most important thing to look into is you see positive hemoglobin H. If you see this thing right here, what do we call this cell? I want to see if someone knows. Golf ball cell. Perfect. All you guys need to memorize. You see this HBH, it's HBH disease. This golf ball cell. Memorize, dump on the exam, move on. Okay, so that's it. Yes, it is basophilic stippling, but basophilic stippling is seen in other diseases. Like, for example, you have lead poisoning that causes it, and some other diseases that can cause basophilic stippling. But I don't think you guys need to know very specifically about basophilic stippling. Now, what finding do I see here? What's this? Schistocytes, perfect. And now, how do I describe, like, what do we give it the name? What does it look like? Basically helmet cells. Okay, so these are schistocytes, okay, which are fragmented or helmet cells. It looks like a helmet. Okay, so anyways, schistocytes. Now, it's fragmented cells. It happens due to mechanical disruption, due to something. Now, can you tell me if someone has schistocytes, he has microangiopathic hemolytic anemia? Okay, very specific type. Now, can you tell me if someone has hemoglobinuria, has thrombocytopenia, and has neurological dysfunction, what disease am I thinking about? Perfect. Thrombotic thrombocytopenia purpura. The other differential, which is very similar to it, is hemolytic uremic syndrome. The most important thing about the two, the difference is neurological symptoms. If neurological symptoms are present, it's TTP. If not, it's HUS. Okay, that's how I remember it. Now, for HUS, it's hemolytic uremic syndrome. It's caused by what infection? Exactly, Shiga toxin or E. coli. In this lecture, I think it's in the hemolytic anemias by Dr. Rayhan. Okay. Um, anyways, I think so. But anyways, this one, it's seen in Shigella infection, E. coli, specifically enterohemorrhagic E. coli. Okay. So it can cause hemolytic uremic syndrome because it damages the glomeruli as these cells, the RBCs, are going through the glomerulus. Firstly, before that, first you have damage in the glomerulus, platelets will start to plug over there. As the RBC is going through the vessels, for example, in the glomerulus, it'll see, like, for example, a platelet plug. So as it's going through it, it's going to start to get damaged and turns into a schistocyte. Okay? So this is what happens, this is what causes the hemolytic anemia. Other than that, you have TTP. TTP is due to a mutation in something called what? What's a mutation, or what's the protein that's defected in TTP? ADAMTS13. Perfect. So ADAMTS13, it's important because it cleaves a certain protein. This protein is von Willebrand factor. Now, von Willebrand factor, as you guys already know and need to know, is that it aggregates or causes the platelet binding, okay? And it also carries factor 8. So ADAMTS13, its function is to cut this von Willebrand factor so it becomes short, okay? So it's not basically showing in the blood vessel wall as much, because if it shows too much, it's going to start activating and binding platelets, which is not good. So what happens in TTP is it's not there anymore. ADAMTS13 is not there anymore. So you have von Willebrand, which is very exposed in the blood vessel wall, so platelets can bind to it. Okay, platelet plug starts to form, and it's exact same thing that happens here. Okay, so that's the difference between the two. Other things that can cause it, for example, aortic stenosis, same mechanism. It's just mechanical friction that causes the disruption of RBCs. Okay, is this clear to you guys? Okay, and don't worry if this wasn't clear. Go to that specific lecture, look at it. Inshallah, it'll be fine. The most ideal things is know what causes each one and how to tell difference. Most likely, it's just going to be neurological function dysfunction. If there's neurological symptoms, think TTP. If not, think HUS. Okay, and HUS is usually following, for example, bloody diarrhea, things like that, because of Shigella and E. coli. Okay, so inshallah, it'll be fine. Now, can you tell me what disease is shown here? Perfect, good. So this is hereditary elliptocytosis, okay? Now this was in your, also in your LGD, I took it straight from that. Again, elliptocytes, you'll see, okay? And in terms of very specifics of it, you don't need to know, okay? Just know that if you see these cells, they're elliptocytes, move on, okay? Now this one is very important. And can someone tell me, what is this disease? Hereditary spherocytosis, good. Now, can you tell me what's one lab value in CBC that will tell you that this might be hereditary spherocytosis? Good, excellent. MCHC, it's high in this disease. Okay, now first question. What's the primary defect causing this? Good. Okay, it's the anchoring proteins or vertical proteins, anchoring proteins, okay? The most important ones are going to be ankyrin, spectrin, band 3 and 4.2. Okay, it's these. Spectrin, ankyrin, band 3 and 4.2. What these do is basically this. In the RBC, you have the cell membrane, and then you have the cytoskeleton for it. The cytoskeleton and the cell membrane, I don't think Dr. Rayhan taught you this, or if he did, whatever, but just to explain it very quickly. The cytoskeleton and the cell membrane are anchored together, but by these proteins, okay? So what this does is normally, yes, Dr. Abdul-Jabbar back in Heme HLS, yes. Basically, it will bind together. What this will do is, as it's going, for example, through blood vessels and stuff, it will distort its shape to make it go through it. That's why if you look at a normal RBC, it's like this, okay? It's like a donut shape, okay? You have that central area pallor, okay? Because the membrane can move around. When you have distortion of this cytoskeleton to cell membrane binding, you'll start to have spherocytes, okay, which is due to a defect in these proteins. And remember all of these proteins very well, okay, in hereditary spherocytosis, okay? Now, what happens is the cell membrane, since it's not bound to the cytoskeleton properly, will start to blub off, okay? Starts to bleb off. So the older cells will be small. The younger cells will be big. So since there's a discrepancy in the size, what value will be elevated? RDW, okay? Now, what's causing the hemolysis in this disease? Spleen, excellent, good. Because these RBCs are no longer able to distort its shape to go through the spleen, it's going to be stuck there. So the spleen is going to look at it and like, okay, I need to get rid of you. So it's going to phagocytose it, kill it, hemolysis, okay? So now, that concept is there, so I'll ask you a question later on about this. Firstly, how do you confirm the diagnosis for this? Okay, I saw three different answers in chat. I'll go over every single one of these. The first one I'm going to take is fragility test. Fragility test is correct. However, it's the old test. We no longer do osmotic fragility test. So this answer is technically correct. However, there's a better answer, which is flow cytometry with EMA. Okay. So EMA is eosin something. Okay. I forgot the rest of it. But basically what this EMA does is it binds to band 3. Okay. It binds to band 3. When you do flow cytometry to normal RBCs, it will be high. Okay. Because EMA will bind to band 3. Okay. Band 3, which is normal. Okay. Band 3 should be there. However, in hereditary spherocytosis, it's not there. Okay. It's mutated. So that means that the binding will be low, so you will not detect this. Okay, so this is how we confirm the diagnosis of hereditary spherocytosis. Coombs test, will it be positive or negative? Negative, good. What do we differentiate using Coombs test? Hereditary spherocytosis versus what? Autoimmune hemolytic anemia, perfect, good. That's important because you do see spherocytes in autoimmune hemolytic anemia, specifically the warm type. Good. Now, what's the treatment for this? How do we resolve the anemia? Exactly, splenectomy. Okay, good. Cut the spleen out. Perfect. Now, will this resolve the anemia? Yes or no? Yes, less hemolysis, which means it will resolve the anemia. That's why you have anemia, because of the hemolysis. So it will resolve the hemolysis. Will it resolve the spherocytes? No. Okay, spherocytes will still be there. However, the main reason why there's hemolysis is because of the spleen. So if you remove the spleen, no hemolysis, no more anemia. However, spherocytes are still there. Okay, and usually fine. It's fine to see hemolysis. It's just, I mean, not hemolysis. Sorry, it's fine to see spherocytes in blood. It's just the hemolysis. It's what's causing the disease. Okay. Now, what's the inheritance pattern for this disease? Last question, then I move on. Okay. This disease is autosomal dominant. Okay. So just remember that. It's autosomal dominant. Okay. Now moving on. Can you tell me first what disease are you thinking of? Then we'll go into specifics of each thing. Okay, good. It's G6PD deficiency. Good. Now, what do we call this? Heinz bodies. Good. Are we using a specific stain or is this just peripheral blood smear? Good. Or we can call it Heinz preparation, superviral stain. Both correct. Good. Now, the next picture. What do we see here? Bite cells, good. Now, G6PD is due to what? Can you tell me what's defected in G6PD? Okay. What does G6P, glucose 6 phosphate, do? Okay. So if you guys remember, glucose 6 phosphate, yes. So glucose 6 phosphate is important in the pentose phosphate pathway. And in the pentose phosphate pathway, it's responsible for giving you NADPH. Okay. NADPH is very important because it's what's responsible for giving you reduced glutathione. Okay. Now, what's a function of reduced glutathione? It basically will reduce the reactive oxygen species. Okay. So this eliminates the reactive oxygen species. It removes them. So that way you don't have oxidative damage. Now, in G6PD, what happens is this: when a patient, for example, gets exposed to a certain trigger, the most common trigger is going to be infection. Then you'll have certain other things such as favabines and some other drugs, for example, anti-malarial drugs and so on. Once this happens, it'll be high amounts of reactive oxygen species. Because the RBCs now don't have the ability to reduce glutathione and then eliminate the reactive oxygen species, it's going to start to denature the hemoglobin. Okay. Now, what happens with the hemoglobin is that the globin chain will denature and give you this Heinz body. Okay. This RBC with the Heinz body is going to go all the way to the spleen, and the spleen is going to look at it. This ain't normal. I need to get rid of this and bite it off. That's why you have bite cells. Okay. This is what's causing hemolysis. Okay. This specific thing. Now, how do you diagnose this? What's a diagnostic tool? Glucose 6-phosphate dehydrogenase levels. Good. Now, would you do this when someone's having an acute attack? Yes or no? No. Excellent. After the attack, you check this and you check. How do you manage this patient? Avoid the triggers. Perfect. Excellent. Okay. This is everything I think you need to know about G6PD deficiency. Now, can you tell me what you see in this image? Howell Jolly bodies. Excellent. Okay. What are Howell Jolly bodies? Clusters of DNA, okay, or DNA remnants. Perfect, guys. Now, can you tell me what's the underlying cause? Don't tell me specific. Don't tell me very, very specific thing. Tell me general. What can cause this? Perfect, good. Hyposplenism or asplenia or spleen defect, splenectomy, whatever, okay? Hyposplenism, okay? So now, in the case of sickle cell, someone already mentioned sickle cell. This is very true because sickle cell will cause autosplenectomy. Okay, it will basically kill the spleen. So in this case, because the spleen is not going to be able to see these DNA fragments and remove it, it's going to stay in there. So this is going to precipitate as Howell-Jolly bodies. Okay, that's the concept. Once you see this, think hyposplenism, then figure out the cause. It could be seen in hereditary spherocytosis after you remove the spleen, could be seen in a lot of diseases. Okay, so that's why you think, okay, hyposplenism can cause this. That's it. Okay. Now, I want to just go over the symptoms of hemolytic anemia very quickly. So in hemolytic anemia, if it's, for example, extravascular, which means where is the hemolytic anemia happening? Spleen, perfect. What symptoms would the patient have? Other than signs of anemia, give me one very important sign of extravascular hemolysis. Other than splenomegaly, jaundice. Very important to remember jaundice. Why? Is because again, hemoglobin is heme plus globin. Heme is iron plus protoporphyrin. Protoporphyrin will be converted to unconjugated bilirubin. Unconjugated bilirubin, this is normal, will go back to the liver and will be conjugated. However, the conjugation will be too much because there's so much unconjugated bilirubin now that it can't be conjugated. So it will be high. So you'll have jaundice. Okay. In intravascular, which means inside the vessels, you will see more of hemoglobinuria. Okay, which means blood in or hemoglobin in the urine. Okay. You'll see more of that as well, plus the signs of anemia. Okay, so that's how to tell differences between intravascular, extravascular hemolysis. Okay, now this patient over here. What do you think the disease is? Now, this image, I will tell you, is very difficult, not gonna lie for me. Like if I see this image, I will not think of this disease immediately, not gonna lie. So I put it here just for the sake of completion. Exactly. This is autoimmune hemolytic anemia, specifically warm. Okay. Warm autoimmune hemolytic anemia. Now, can you tell me three findings? Let's go in order. What's the cell? Cool. This one. Reticulocyte, axon or a polychromatic cell. Perfect. Okay, it's a reticulocyte. This cell. Nuclear RBC. Okay, these are the three findings that you need to remember in the case of autoimmune hemolytic anemia. Now, for autoimmune hemolytic anemia, there's two types, warm and cold type. Now, warm type, can you give me two causes of warm type hemolytic anemia? SLA, perfect, and one more. Lymphomas, good, and CLL even. Okay, now for cold type, give me the two important causes. Okay, good. So in cold type autoimmune hemolytic anemia, it will be because of mycoplasma pneumonia and EBV causing infectious mononucleosis. Okay, so these two are the causes of cold type. Most important thing to remember about them. You see a patient with cold type autoimmune hemolytic anemia, they most likely will present with signs of intravascular hemolysis versus warm type, which will most likely be signs of extravascular. So you'll have jaundice, splenomegaly, all these things. You'll think of the causes. Okay. How do you diagnose this disease? Coombs test, good, or direct antibody testing. Now, there's two types, there's direct and indirect. I don't think it's very too important to remember the two, but basically direct, if you're seeing antibodies that's directly binded to the RBC. Indirect is you're seeing the serum if there's antibodies present. That's basically the difference between them. And it'll be positive in this. Let's just say we did osmotic fragility test. Will it be positive in this disease? Yes. Why? Perfect. Good. MashaAllah, guys. Spherocytes. Okay, that's important thing to look into. You see spherocytes, what's it called? Osmotic fragility test will be positive. Good. Now, can you tell me what disease are we looking at? Aplastic anemia. You see a hypocellular bone marrow, aplastic anemia. So much fat, less RBCs or less, what's it called? Any of the bone marrow constituents other than fat cells. Okay, so this is aplastic anemia. Can you give me a genetic cause of aplastic anemia? Fanconi's anemia. Good. Perfect. So for Fanconi's anemia, you think of you see aplastic anemia, that's number one. And you'll have other manifestations such as skeletal abnormalities, they'll have dysmorphic features. In their fingers, they'll have polydactyly and stuff like that for Fanconi's anemia. Okay. Some other causes, you'll have certain drugs that can cause aplastic anemia, certain infections, such as parvovirus infection, can cause aplastic anemia, and stuff like that. Okay. This is aplastic anemia. That's it for this. And we're done with hematology. Is there any questions? Is everything clear? Because I went over a majority of it. There's a few more diseases I skipped over. For example, PNH, paroxysmal nocturnal hemoglobinuria. Know the diseases. What's the underlying cause of sickle cell? Sickle cell is genetic disease. You have the mutation changing from glutamic acid to valine, and this causes it to basically, because valine is going to be now hydrophobic, so this will cause it to sickle, okay, to denature. That's underlying cause of sickle cell. Does the doctor ask a lot about treatment? Not too much. It's just mostly to test your concept. So, for example, when I mentioned what's it called, hereditary spherocytosis, if you remove the spleen, it removes anemia, but does not remove the spherocytes. This is a concept question. It's not a direct management question. Later on, like in this part, specifically in oncology, you do need to know specific. You need to know everything in oncology. Not gonna lie, you need to know the specific chemotherapies I can use with each type of leukemia and lymphoma. Okay, that yes, you need to know. Okay, so I will begin now with oncology. I will start with lymphomas. It's the most complicated part of heme onc for all of us, but we'll start with simple and we'll build it up. And again, interactive session. And if you have any questions, please. So now, in normal lymph node, you'll have the cortex and then you have the medulla over here. So in the cortex, you'll have these. What do we call these guys? Follicle. Okay. Is this a primary follicle or secondary follicle? Secondary. Why? Germinal center. Perfect guess. Okay. Then you will have the paracortex, which is going to be below it. Leave the second line, but basically it's going to be right below it. This is going to be the paracortex. And then you'll have the medulla, which will have the sinus areas. Okay. Anyways, in the cortex, what type of lymphocyte will we see predominating? B cells. Perfect. Paracortex. T cells. Perfect. Good. This is very important. Now, in the sinus, what types of cells will we see? Histocytes, which are, and all cells pretty much. But I want to very importantly mention histocytes, which are basically macrophages. Okay. You will see these in the sinus areas. Okay. Okay. Now that we got this, we know the normal lymph nodes. I will ask you about the CD markers now. If you have a cell that's CD 3, 3 and 8, 3, 4, and 8, what cell am I looking at? T cell. 19, 20, 21. B cell. These are the simple ones. However, later on, when we go into very specific diseases, I'll ask you about the specific CD markers. But if you know the B versus T cell, this is very important for the rest of this segment. Okay. Now I will go into this. Can you identify what's this image first? Good. It's follicular hyperplasia, not lymphoma. I'll explain why in a second. What's this one? Sinus cysticercosis. Good. Now, sinus cystocytosis and follicular hyperplasia is seen normally after infection. Okay, you have infection with something that causes these things. Normal, okay? Because normally at the site of infection, you have the antigen presenting cells goes all the way to the lymph nodes and presents it there. Then it starts to do its thing. Okay. Now, how do I know that this is follicular hyperplasia versus if this is a lymphoma? Okay, which is cancer, it's malignant. Number one, does this disrupt the normal orientation of the lymph node? This follicular hyperplasia. Meaning, will you see these follicles developing in the sinus? No. In follicular hyperplasia, all the follicles will be in the cortex. Okay, normal. It's a normal lymph node. It's probably just enlarged as well. Okay, that's number one. Number two, in cancers, usually cancers, if you remember from neoplasia and POD, it's monoclonal. Okay, follicular hyperplasia is polyclonal. That's number two. Number three is genetics, and I'll explain. It's like a mutation or something that's going wrong. I'll explain this when I get to the actual lymphoma, not now. And number four is you'll see presence of certain types of macrophages inside the follicle itself. These are called tingible body macrophages, okay? What they do is this. Now, follicles, you'll have developing B cells, okay? B cells will go through something called somatic hypermutation. What this means is it's going to see an antigen. Can it bind to it? Can it not? Can it produce antibodies, against it? Yes or no? If it can't, it has to die. So it goes through apoptosis. Because of the apoptosis, you have these macrophages that comes in the phagocytosis. So you'll have to see a presence of macrophages. It's not present in the lymphoma. And I'll explain again why this is the case and when I get to the lymphoma, so don't worry. In sinus cystocytosis, you'll have high amounts of macrophages and stuff because of the infection, okay? That's as simple as that. Now, we'll go through the rest of this images. Now, can you tell me what are we looking at here? Can you tell me the cell? Don't tell me the disease. What's the defect here? Don't tell me the disease yet. Reactive lymphocytes, okay. Atypical lymphocytes, okay. They're atypical. Now, tell me now the disease that you can see this in. Perfect. Infectious mononucleosis, and you can all excellent, perfect. EBV, and less commonly is CMV. Okay. Cytomegalovirus. Good. Okay. What specific laboratory findings, if you're suspecting a patient with infectious mononucleosis, are seen in the acute setting? I want 3 findings. Okay, good. Viral capsid antigen, IgM. Good. That's number 1. IgG. Good. One more. Excellent. Good. It's everything except the EBNA. Okay, the Epstein-Barr virus nuclear antigen. Okay, good. It's everything except that. Now, if it becomes chronic, will you see this? No. That's very important. If it becomes chronic, no. And you'll start to see E, if I can write this properly, B, N, A. There we go. Positive. In the case of chronic, okay? Now, what type of cells are these anyways? These atypical lymphocytes. No, they're not B cells. CD8 toxic T cells. Good. Okay. So these are CD8 toxic T cells. Okay. Just remember that. Now, probably the most important picture that you'll see in this, actually, no, there's 2 very, very high yield pictures in oncology. This is number 1. What finding do you see here? Reed Sternberg cell. Perfect. Good. What type of lymphoma is this seen in? Hodgkin's lymphoma. Perfect. Good. What are the CD markers? 30 and 15. Perfect. Very important, guys. Remember the CD markers. Remember the CD markers, please, 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 for your exam. CD30 and CD15 for Reed-Sternberg cells. Okay. Now these are excellent. That's actually the way I memorize it. 15 times 2. Okay. So 2 because there's two nuclei, two eyes of the cell, so it equals 30. Good. So that's one way to remember this. Okay. Now, which subtype has many Reed-Sternberg cells? And it's the worst prognosis. Perfect. Good. Lymphocyte deficient. Now, or depleted. Perfect. Now, there's 4 types of the typical or classical Hodgkin lymphomas. There's nodular sclerosis, mixed cellularity, lymphocyte predominant, and lymphocyte depleted. The more lymphocytes are present, the better that it is. Okay, the less Reed-Sternberg there is, the better that it is. Now, Hodgkin lymphoma, what's the most common subtype of Hodgkin's lymphoma? Nodular sclerotic. Okay, good. Now, what these Reed-Sternberg cells do is they start secreting cytokines. Okay, now these cytokines, firstly, will start to attract lymphocytes, which you can see around the Reed-Sternberg cell. That's why there's a lymphocyte predominant, lymphocyte depleted, and all these things, because of the cytokines that they produce. And also, the most common symptoms that they have is something called B symptoms, which is because of the cytokines that gets produced. Now, these B symptoms are basically fatigue, fever, more specifically, fever, night sweats, weight loss, all these things, okay, are B symptoms. So that's the signs and symptoms. Most of the Hodgkin lymphomas are seen in males mostly, except one. What is this type? This is nodular sclerosis. Okay, so you'll have nodules cut by bands of fibrosis or collagen, which is why it's causing these nodules. Between the nodules are basically these fibrotic areas. These are nodular sclerotic, okay, or sclerosis. This is most likely seen in females. Okay. Next one. What's the subtype here? First, you can tell that this is a Reed-Sternberg cell. Now, what's around it? Mixed cellularity, good. What are, for example, this cell? What is it? That cell? Or any of the red cells, what are they? Since it's mixed cellularity, so you'll see many cells. What's the red one, for example? Eosinophils. Okay, so you'll see many types of cells. That's the main important point for this. Okay. Now, can you tell me what disease is this? Good. SLL. What's another name? CLL. Okay. Perfect. Small lymphocytic lymphoma or chronic lymphocytic leukemia. Leukemia if it's blood, lymphoma if it's lymphoma. Okay. And they're small cells. Now, what age group is most likely affected in this disease? Perfect. Elderly above the age of 60. What type of cells are present? Is it B cell or T cell? Good. B cells. What is the size? Small, intermediate, or large? Small. Perfect. What markers are positive? #20 and 5. Good. CD20, it's a B cell marker. And 5 is the same thing. Okay, but 5, if you think about it, for T cell markers, it's CD2 to 8 typically, but 5 can be seen here as well. And 5, remember it here, CD20 and CD5. It's most likely in elderly. It's one of the most common types of leukemias in elderly, if CLL. And that's pretty much it. That's all I think that you need to know about it, except this. Okay. Now, in this one is, what's the disease first? CLL. Perfect. Now, all of these are lymphocytes, okay? They're the neoplastic lymphocytes, okay? They aren't blast cells because it's chronic, okay? That's number one. But the main cell that I want you guys to look at is this big one, okay? What do we like describe the cell as? I don't know if you guys actually like detail took it because I've never seen it described as that, but I might take it because like literally any description that works for you works. But usually what it's called is smudge cell because it looks like someone literally took the cell, put it on a plate and smacked it. Okay. So that's why we call it smudge cell. Okay. But popcorn, I can see why you can call it that. But anyways, this is CLL. Okay. Now, what disease is this? Diffuse large B cell. Good. Okay. This is the worst prognosis, worst one out of all the B cells. Okay. It's literally the worst one. Okay. To have worst prognosis. Diffuse large B cell. What age group is most likely affected? All. Good. Something to think about for this diffuse large B-cell lymphoma is a lot of the cancers. So, for example, follicular lymphoma, for example, certain types of leukemias, the complications of them is to develop into this because this is the worst prognosis, worst type to get. Okay, so that's why you think about it, it's in all ages because certain types of tumors, for example, ALL, for example, is most likely in children. You have, for example, Burkitt's lymphoma, again, most likely in children. I'll give you guys tips for the next few slides. Anyways, it can turn into this, and this is the worst prognosis. Okay, what types of cells? It's in the name. B cells, and then what's the size? Again, it's in the name. It's large. Okay. Now, the reason why it's called diffuse, just for you guys' info sake, is most of these cancers are named based on where it's located in the lymph node. Okay, because we'll go into the details of it next. But basically, for example, follicular lymphoma is most likely from the follicles. You have mantle cell lymphoma in the mantle zone. You have marginal zone lymphoma, but it's most likely outside of the lymph nodes. And then you have diffuse, which is all throughout the lymph node. Okay, so that's why it's called diffuse large B cell lymphoma. Now, what markers are positive in this? Good. Okay, perfect. 90, 20, B cell markers. Okay, simple. Now, can you tell me what disease is seen in this image? Follicular. Is it hyperplasia or lymphoma? Lymphoma. Okay, good. Now, what age group is affected? Elderly, most likely in the elderly. Good. What types of cells are these? B cells, perfect. And again, it's from the germinal centers. Now, what's the specific translocation seen in this lymphoma? Good. Okay. Now, tell me what the markers are. It's 14, 18. Now, what are the markers that are positive? Tell me the general markers. Tell me, okay, that one's, and then tell me what two specific markers are positive. Excellent. Someone already said all of it, mashallah. BCL 6, 2, 10, 19, 20. Now, time for me to explain just a very specific concept. Okay. Now, can someone tell me what is the function of BCL2? Opposite. Okay. It's not pro-apoptotic, it's anti-apoptotic. Okay. Now, time to explain this concept. 14, 18. Okay. You'll see number 14 in majority of these lymphomas, right? It's in a lot of them. Now, to explain why is 14 important is this. Chromosome 14 has something called the Ig heavy chain. Okay, if you remember the immunoglobulin or the antibody, you'll have a heavy chain, light chain. Okay, the heavy chain is always expressed. Always expressed. BCL2 is on chromosome 18. So when you have translocation to chromosome 14, it's going to cause it to become overexpressed. So BCL2 will be high. Now, usually in all cells, that's normal. You know, you want to have BCL2 because it inhibits the mitochondria from releasing cytochrome C and causes apoptosis. Okay, that's what BCL2, but it's not, you know, overexpressed. It's not high. It's not normal to have high amounts anyways. But what I'm saying is in specifically the lymph nodes and specifically the follicles, you kind of do need apoptosis. Why is, as I said, is somatic hypermutation. If the B cells cannot produce the antibodies that binds to the antigen, it dies. Okay, so without BCL2, it will never die. So this, I mean, with BCL2 overexpressed, it will never die. Okay, so that's why you have firstly monoclonality. Number two is it's gonna have BCL2, so it makes it anti-apoptotic. It's immortal cells. Number three is I told you in the follicular hyperplasia, you'll see tingible body macrophages in the follicles. You will not see this. Why is that the case? Because there's no apoptosis. Okay, there's nothing to clean up. It's going to keep proliferating, that's it. Okay. Number four, to tell the difference between hyperplasia, is the fact that can you tell what's the cortex, what's the medulla, what's the pericortex? No. Okay, you will not be able to. It basically makes it deformed, the lymph node. Is this clear? Okay, this is just for your concept so you can like remember it easily. That BCL2 is what causes all of this. Okay, perfect. Now I need you guys to remember number 14 because most of the next lymphomas, okay, will come next. Okay, which will have number 14 in it. It's just something that's on the other chromosome goes to 14 and causes a bunch of stuff. Okay, so let's go to the next one. What's this one, guys? Mantle cell lymphoma. Perfect, guys. Whoops. Good. So mantle cell, if you look into the follicles, will be around the germinal center, just for the concept's sake. Anyways, mantle cell. What age group is affected? The questions that I have here are most common, like most things that Dr. Ahmad focuses on, age, you know, how to classify lymphomas. That's why it's repeated everywhere, like in my slides. In adults, okay. What type of cells are these? Since it's next to the germinal center, it's still in the cortex. B cells. Okay, good. Now, what's the translocation? Good. 11 to 14. Perfect. What markers are positive? Good. And one very specific one, cyclin D. Good. Now, again, concept. Cyclin D1. Okay, does anyone remember what the function of cyclin D1 is? For mitosis. Excellent. Good. Exactly. So what this does, cyclin D1, is it progresses the cell from G1 to S phase. It basically speeds up the cell cycle. Okay. So cyclin D1 is on chromosome 11. Okay. So what's on chromosome 14? I already mentioned it. Ig heavy chain. Okay. It's overexpressed. Gets translocated. Cyclin D1 is now overexpressed. It's gonna push it from G1 to S phase. It's gonna keep the cycle going. So this means there's high proliferation. Okay, that's what causes mantle cell lymphoma. Remember these markers. Remember this translocation very well. Okay, next one. Now, CD5, as I mentioned before, it's usually not in B cells, but because it's cancer, it's CD5. CD5, CD20 is like, it's just like CLL, okay, because they're cancerous. Actual explanation, I have no idea. It's just something to remember. Anyways, what's this disease? Burkitt's lymphoma. Perfect, guys. Can you tell me what do we call this appearance? Starry sky. Perfect. Okay. The starry sky appearance. Now, which age group is most likely affected? Children. Good. Now, for this, I want to just take you on a specific tangent. For Burkitt's lymphoma, if you see a mass on the neck with most likely an African child, think Burkitt's lymphoma. Okay. Immediately. Think Burkitt's lymphoma. Okay, it's the most common presentation, a mass in the jaw. Okay, is most likely in Burkitt's lymphoma, and Dr. Ahmed didn't mention this, so I will just say this, but you don't need to remember it. There's two variants: the African variant and then everything else. African variant is the mass in the jaw. Everything else, most likely presentation, is the abdomen. Okay, the sporadic one. But anyways, don't remember that. Just remember if you see a mass in this, think. Oh, they mentioned micro. Okay, interesting. Okay, then remember it then. Uh, anyways, what type of cells? B cells, good. Translocation, 814, good. And what markers are positive? Excellent, guys. Okay, perfect. Now, one more concept, and then it's not located here, but I will explain it through this. Chromosome 8 has something called c-MYC. Okay, c-MYC, what it does, it's an oncogene. Oncogenes, it will cause it to cause basically cells to proliferate and cell growth. Because it's moving to here, that's why it's causing the cancer. You don't need to remember this. Just for your concept sakes, that's to explain why this cancer happens. Okay. Anyways, children, think of that. Think of Burkitt's lymphoma. You see a mass like this, think of Burkitt's lymphoma immediately. Remember these markers. Very important to remember these markers. Now, what disease is seen in this image? Mycosis. Good. Now, mycosis is in mycosis. Okay. What type of cell is this? Like what cell neoplasm is this? B or T cell? T cell. Perfect. Okay. So Dr. Ahmed, I don't think mention what this finding is, but it's in my slide notes. I honestly do not know how to pronounce it, but it's called Fortier's microabscess. Anyways, it's basically it starts off in the skin. It's a T cell neoplasm, starts with the skin. Once it becomes leukemic, which means it's in the blood now, it's called Sézary syndrome. Okay, that's all you need to remember about it. Now the next thing is this: what cell? What disease is this? Anaplastic T cell lymphoma. Good. Okay. What age group is affected? Good. What type of cells? Good. Translocation. 2 to 5. I don't have any explanation for this translocation. Just memorize this, not gonna lie. For that, there's what type of cell is involved is mostly through markers, which is T cell markers. Okay. It's mostly through the markers, but in terms of like an easier way to memorize them, not gonna lie, I do not know. But Saeed in chat has been going off with the easy ways to memorize, so go with that. Okay. ALK is positive, very important to remember in anaplastic large cell lymphoma. And basically what you look at in the slide itself is they're anaplastic cells. Well, many doctors say that this is a very ugly tumor. You don't know what you're looking at. I do not know what to tell you about this slide. Just very ugly. Anyways, 2 to 5 translocation and ALK anaplastic. Okay. Now, can you tell me what this one is? Give you a hint. This is most likely a child. Most likely a child. And they have a mass in the mediastinum. Lymphoblastic lymphoma, good. I will just add acute to it, but anyways, good. Lymphoblastic leukemia or lymphoma. If this is a mass, there's a lymphoma, leukemia is in the blood, obviously. What age group is affected? I already mentioned children. What type of cells are these? It could be either. Okay, good. Size, they're intermediate. And now markers. Now, before you tell me the markers, which is very simple for this one, I want you to tell me, if this is a lymphoblastic leukemia or lymphoma, what's the most important marker to tell me that this is lymphoblastic? TDT. Okay. TDT, once it's positive, think lymphoblastic, either leukemia or lymphoma. That's high yield, very, very high yield. Okay. TDT. Now, how do you differentiate whether it's a T cell or B cell? By the markers. What are T cell markers? Good. 3 to 8. B cell. 1920. Okay. These are some of the ones that I've saw through the slides. So yes, that's everything that you guys mentioned already. Good job. Remember this very specifically. Yeah. What's this going to? It's basically the same thing we saw previously, but it's leukemia now. So what do we call it? Acute lymphoblastic leukemia, ALL. Now, these are lymphoblasts. Okay, so again, what's the marker that tells me this is lymphoblastic? I'm going to highly stress on this. Very important, TDT. Okay, now, what age group is affected? This is important also. Children. It's the most common leukemia in children, ALL. Okay, now ALL could be B cell or T cell. If it's a T cell lymphoma, T cell leukemia, most likely the presentation is in a young child, again, same thing, but presenting with a mediastinal mass. Mediastinal mass is very important, like, feature that you'll see in it. Anyways, that's that. Now, since it's a acute lymphoblastic leukemia, what's the blast percentage? More than 20%. Perfect. Good. Now, ALL has two types of translocations. There's a good one that's in children, which is what you're going to see mostly, and there's a bad one. Okay, tell me what the good one is. 1221. Perfect. What's the bad one? 922. What's this Philadelphia chromosome? Perfect. Good. So this is the Philadelphia chromosome. We'll explain this when we get to the cancer that's most likely seen with the Philadelphia chromosome. Okay. But anyways, this is the Philadelphia chromosome. And I think also the translocations that I explained, I'm pretty sure Dr. Al-Jada explained them now that I remember it. I could be mistaken or not, but if I did explain them and it's on this slide, it works. Not gonna lie, I kind of forgot what was in his lecture. Anyways, what disease is seen in the following image? This is probably the most important one to identify. AML. Good. Acute myeloid leukemia. Now, to tell me that this is acute myeloid leukemia without seeing this, what's this firstly? I want you guys to tell me what this thing is, our odds. Now, if I didn't see our odds, how would I know this is acute myeloid leukemia? What test or what's a marker that I would look at to tell me this is myeloid? Excellent. Myeloperoxide. Good. Basically, our odds are just basically condensed myeloperoxidase. Okay, so that's basically what our odds are. What age group is affected? Adults. Good. Blast percentage? I mean, it's acute, so above 20. Mention two features in the image. Now, what's another feature of myeloid cells? What do all myeloid cells have in their cytoplasm? Granules. Good. Okay, perfect. That's pretty much that. Now, acute myeloid leukemia has many subtypes based on the translocations and prognosis. I do not think you need to know any of them except one very important one, which we'll get to in the next slide, which is this. What is this subtype called? Acute promyelocytic leukemia, APML. Okay, which is exactly M3 or the subtype. But anyways, no, it's APML. What's translocation? I already mentioned it, 15 to 17, which is basically, yeah, this one is very important. Morphology, you need to know AP. This is APML. It's very simple, similar to AML, but I think they're gonna bring it separately. Okay, so it's either a picture of AML or APML. If they put it together, this is something I would personally appeal. Okay, but anyways, because they both have the same findings pretty much, but there's more hour odds here. Anyways, it's the PML to what is RAR alpha, RAR alpha. This is important in the pathogenesis and the treatment. Retinoic acid receptor. Good. Now, retinoic acid receptor, it's in the promyelocytes. It's basically needed. You need retinoic acid, which is vitamin A, and there's a specific type that you give to these patients to make it differentiate from the promyelocytic phase to the rest. Okay, so that's that. Two features in the image, it's our rods, and then you have promyelocytes as well. Now, what is a treatment for these patients? Oh, trans-retinoic acid. Good. Okay, perfect. Once you give this, this will start to differentiate the cells from one phase to another. Okay, so this is all trans-retinoic acid. Now, tell me what disease this is. So yes, this is myelodysplastic syndrome. Good. Now, myelodysplastic syndrome, can you guys tell me what's the blast percentage? Okay, it's below 20%. Okay, it's high, but it's below 20%. In acute leukemias, it's above 20%. Okay, that's number one. This cell, I don't think you need to know, identify these cells, but it's basically a neoplastic cell with multiple nuclei. Now, this one is high yield to remember. What is this image showing? Sideroblast, good. It's a ring sideroblast, which is what are these blue granules staining for? If you guys know, iron, good. So it's iron around the RBC, okay, good. Now, can you tell me what disease is in this image? CML, good. Chronic myeloid leukemia, good. Now, what's the translocation that's seen in this type of leukemia? This is a very high yield, 922, good, which is the BCR ABL translocation. ABL is on chromosome 22, BCR is chromosome 9. Once they translocate, it will translocate to 22, so it'll be in BCR ABL, which is a tyrosine kinase, okay? So it will cause the cell to overproliferate, okay? Now, because of this information, it's a tyrosine kinase. How do you treat this disease? Tyrosine kinase inhibitor. Tell me the drug name. Imatinib. Good. Remember imatinib really, really well. Okay. This is very important. Also, I want to ask about another drug. If you have a cancer that has CD20 positivity, what drug can you use? Rituximab. Perfect. Good. Know these. It's very, very high. Okay. Now, what is seen in this image? Okay. If there's CD20 positivity, you treat it with rituximab, which is an anti-CD20. Okay. Imatinib is a tyrosine kinase inhibitor, so you treat CML with imatinib. And it's just a random question I ask about rituximab. Okay, what is seen in this image? Okay, so in terms of this, interesting, but yes, okay. Basically, you'll see many lineages, okay, lymphocytes, okay, and immature neutrophils, okay, which are band cells, as you mentioned already. Now, I want you guys to mention very specifically these cells. These cells are what? I know they appear a bit red, but they'll be a bit bluer. I'll give you a hint. Basophils. If you have a patient with basophilia, high basophils, think CML. Okay? Very important. Also, their leukocyte count or lymphocyte count will be so high, WBCs. Now, concept. Can you guys tell me what a leukemoid reaction is? Exactly. It's more than 50,000. Good. Now, this is seen in a leukemoid reaction and in CML. Okay, leukemoid reaction can happen due to severe infection. It needs to fight off the infection, something happens, right? Now, how do you tell the difference between them two? How do you tell? Exactly. Leukocyte alkaline phosphatase will be low in CML or in leukemoid reaction? CML, perfect. Good. So in CML, leukocyte alkaline phosphatase will be low. That's a number one. Number two, basophilia. You see these two? Okay, now you think of CML. Okay, is this clear to you guys? Okay. Now, can you guys tell me what are the phases of CML? There's three phases. So tell me all three. chronic, accelerated, and blast. How do we differentiate the three phases? Blast cell percentage. Good. Now, let's just say someone has CML and is starting to be treated with imatinib. How do we know that the patient is responding to imatinib and is recovering? There's three. Okay, there's three things to look at. Raha, I forgot them, but look into Dr. Ayhan's slides. He emphasizes so much, but it's basically, I think, looking into the Philadelphia chromosome, if it's still there or not, looking into the translocation, and some other thing as well to look into. Okay, these are very important. So I'm just telling you, mentioning you, go and find that and know that very well. Okay. Now moving on to this one. What's the disease here? Myelofibrosis. Perfect. Good. So this is myelofibrosis. What do we call this cell? Teardrop cell. Perfect. Good. Now, what do we say this is? Splenomegaly. Good. Now, what is this showing you? This image? Fibrosis. All right. This is reticular stain. Okay. So this is, as you mentioned, myelofibrosis. Okay. Perfect. Someone already mentioned it. Detailed answer. Trifine biopsy showing reticular. Good. Now, myelofibrosis, again, in the bone marrow, you'll have fibrosis. Okay, simple. Okay, you have replacement of the normal bone marrow cellularity with collagen and with reticulin and stuff others, cause of fibrosis. Now, because of this, you have ineffective erythropoiesis, similar to beta thalassemia. I mentioned that before. And then you'll have extramedullary erythropoiesis. Now, these cells, as it's trying to leave the basically the what's it called, the bone marrow or anything, it's gonna be too big. So as it's going through, a membrane part of it will be basically, try to switch through the bone marrow. Okay, so that's why you have this, and because of the ineffective erythropoiesis, you'll have nucleated RBCs. Okay, so that's myelofibrosis. Now, this is, I think, the last slide in the oncology section, and then we're going to micro, which is very fast. Okay, so now can you tell me what disease is this? It's multiple myeloma. Perfect. Now, multiple myeloma is a neoplasm of what cell? Plasma cells. Perfect. So these are plasma cells. Good. Now, in multiple myeloma, can you tell me some features that you might see? Osteolytic lesions. ESR is high. Good. And these are the osteolytic lesions. Hypercalcemia. Would you have renal failure? Yes or no? Renal insufficiency? Yes. Why do you have renal insufficiency? Okay. So what happens in multiple myeloma is plasma cell neoplasm. Okay, this is going to start to cause release of one, for example, IgA. It's either IgG or IgA. Okay, high amounts. Okay, of M protein. So you'll have high amounts of albumin, high amounts of protein in the plasma. In the immunoglobulin itself, it's gonna be basically basically you have the light chain and heavy chain, as I already mentioned. Now, this light chain, when it goes to the kidney and gets secreted, it gets secreted at something called the Bence-Jones protein. Okay. Now, this Bence-Jones will accumulate in the kidney, causes acute kidney injury. Okay, that's number one. Number two is multiple myeloma. You have a high amounts of cytokines. These cytokines will activate osteoclasts. Osteoclasts will start to break down bone, causes these osteolytic lesions. So commonly they'll have back pain, they'll have fractures, they'll have all these things. That's number one. Number two is you'll have high amounts of calcium. Calcium is bad. Calcium starts accumulating in the kidney, causes the kidney damage as well. So that's why you have kidney damage. High amounts of protein in the plasma as well will cause the charges in the plasma to be disrupted. So RBCs are going to start to clump up together to form what do we call this? Rouleau formation. Okay, good. Perfect. Now, how do we diagnose patients with multiple myeloma? Exactly. Okay. So you see the protein spike. Okay, the M protein spike. Okay, this M protein spike, it's either IgG or IgA, very high amounts of it, and this is the M protein spike, diagnostic of multiple myeloma. Okay, a good mnemonic to remember is CRAB. What's it called? Hypercalcemia, renal insufficiency, anemia, and then bone lytic lesions as the clinical manifestations of multiple myeloma. Okay, so that's that. Are there any questions for oncology? Or is everything clear? Micro is going to be very short, so I want to go over it more quicker. So that way we can finish faster. There's one more thing I think I want to go through. I think no, never mind. Oh, okay. Oncology is done. I'm gonna go start with microbiology. Okay. This will be a very quick part, so we need to finish faster. And I want a disclaimer. I'm not gonna lie, a lot of these things are very new this year. A lot of the things that you guys are learning in micro this year. For us, for example, for malaria, we only needed to know falciparum, how it looks like and everything. Also, we do need to know the description of all the other strains. However, for morphology's sake, is only falciparum. So this time, you guys need to know all the other types. I have them all included, and I'll try my best to simplify what it looks like. But I also read Dr. Bota's transcription. He's pretty good in explaining how they look like, or like an easy way, funny way to describe it. I'll only ask you guys the important things that you need to look out for regarding all of these strains. But I have a lot of micro involved. It's about like 12 slides or so. So yeah, let's get started. Now, can you tell me what's seen in this image? Firstly, tell me what disease, then I'll ask you specifics of this. Excellent, guys. This is malaria, okay? Can we tell what type of plasmodium this is? No. What type of film is this? Is it thin or thick? Thick film. Good. Okay. In thick film, you basically destroy the RBC. So you won't be able to look into what's inside the RBC. So you'll only see the parasite, which is malaria. You cannot subclassify what the parasite actually is in thick film. Okay. So that's that. Now we'll go into what the organism actually is. Can you tell me what this organism is? Falciparum. Good. Now, falciparum, let's go through this. In this RBC, first, this is thin film, obviously, because you can actually see. What do we say about this feature? Okay, you have ringed shapes. Also, if you look at in thick and thin film, it looks like headphones. Okay, so it looks like headphones. So that's how I can tell this is Plasmodium falciparum. It's a ring circle with either one ring or headphones. Okay, cool. This is super high yield, remember? What is this? Banana-shaped gametocyte. Okay, and remember the cycle for Plasmodium. Mosquito, and then you have the sporozoites, goes in, merozoites, schizones, all these things. Remember them. These are gametocytes, which can be transmitted. Again, mosquito comes for a bite, takes a gametocyte, sexually develops inside the mosquito. Okay, remember the cycle very well for this. So these are the banana-shaped gametocytes, Plasmodium falciparum. Now, for a question. Is Plasmodium falciparum the most severe one? Yes or no? Yes, good. What's okay, if I say Blackwater fever, what strain am I thinking of? It's most likely falciparum. Okay. Now, what type of fever does it cause? Malignant tertian fever. Good. Excellent. So it's either every 3 days or so, or it can be every day as well. That's why it's called malignant tertian. Okay. There's different sources telling you different things. Remember malignant tertian as the key words and go with falciparum in this case. Okay. But anyways, going to the next one. What organism is this? Vivax. Good. So Dr. Botta explained this using either Germans or Italians. I won't do that. I want you guys to remember this is very unorganized. It's just, there's no clear, you cannot describe the cell. You cannot describe what you're looking at, not gonna lie. It's just kind of messy. I would say it's trying to be falciparum, it's trying to form a ring. Okay, that's it. Now, specifics about this one. What type of fever does it cause? Tertian fever. Good. Now, what's the problem with this one? Can it lay dormant? Yes or no? As what? What does it lay dormant as? Hypnozoites. Good. So this lays dormant as hypnozoites. Okay, and it's a tertian fever. Falciparum. Plasmodium vivax. Good. Now, next one. Ovale. Okay, Plasmodium ovale. Now, this one looks like an oval. Okay, so I will say this is Plasmodium ovale. Easy. Again, what type of fever? Tertian fever. Good. And again, can it lay dormant? Yes or no? Yes. And again, as what? Hypnozoites. So the two organisms that can lay dormant inside the liver as hypnozoites are Plasmodium vivax and ovale. Please remember this. Okay. Cool. Now, which one is this? Plasmodium malaria. Okay, good. Now, this one, I can tell that I can form a line or two lines because you can see this RBC over here, and then there's this one over here. Now, this one is kind of shielding itself. It's hiding itself. It's more organized. That's how I would remember this one, okay? So this is Plasmodium malaria, okay? Now, Plasmodium malaria, what's the fever in it? Gordon fever, good. Which means every how many days? 4 days. Perfect, guys. Remember this one because it's the odd one out of all of them. Okay, usually they like to ask the odd one outs. This is an odd one out. Okay, Quartion fever every 4 days, think Plasmodium malaria. Okay, and I already asked this question. And now, what organism is this one in? No, what is this organism? No, Lessie. Good. Now, I think No Lessie is the most recent strain of discovered. I'm pretty sure. If I remember from POD, I'm not gonna lie, I kind of forgot. Anyways, what it looks like. Again, I don't really know how to describe it. It has some green stuff, don't know. But anyways, look at it. I remember honestly for this one, I don't know what to tell you guys. But also another thing is this one. Does it have an intermediate host? Yes or no? Yes. As what? What's the exactly monkey? Good. Oh, doctor said no need to know to recognize. Okay, perfect. Perfect. Good. It's the reservoir. Good. Perfect. So monkeys. Good job, guys. Now we're done with the malaria and Plasmodium species. Let's go to this. Identify the organism. Firstly, go broad, then herpes. Okay, this is herpes. Okay, this is herpes. All of them are herpes. Okay, we go into specifics of herpes now because herpes. Firstly, what do we describe the virus as? Like, tell me, is it DNA or RNA virus? It's a DNA virus. Is it single-stranded or double-stranded DNA? Double-stranded DNA virus. Okay. Now this one is HSV. Okay. Whoops. This is HSV. Now since this is oral herpes, which type? I kind of showed it, but HSV1. Where does HSV2 develop in most likely? Genital. Good. Perfect. So that's that. Now, what's this one? Varicella. Okay, chickenpox. Okay, varicella zoster virus. VZV. Okay. Again, it's a herpes virus and it causes chickenpox. Now, does varicella zoster have a vaccine? What type of vaccine is it? It's live attenuated vaccine. Okay. Remember that, I guess. But basically, the way we describe the varicella zoster and herpes virus is a dude up on rose appearance. I don't know if you guys need to remember that, ignore it. But basically, it's multiple like vesicle lesions all over the body, and they're in multiple stages of healing. Okay, that's just a key description for how varicella presents as. Now, can you identify the organism here? Or not the organism, but tell me what the disease is. Perfect. Crimean Congo hemorrhagic fever. Good. Okay, to answer your question, uh, varicella zoster is chicken pox. Chicken pox is when it's firstly, when the patient's first infected. Later on, it lays dormant, okay, and then it gets reactivated as herpes zoster, which is shingles. Yes. Does that answer your question? Okay. Cool. Now Crimean Congo hemorrhagic fever, how does it get transmitted? Very important. Tick bites. Okay. Now the Crimean Congo, I think specifically it's this one, but you also have other subtypes of hemorrhagic fever. So I'll go into the next ones actually. What the organism is. What is this organism? Okay, what's the book? But you're good. And you're okay, good. Yellow fever. Okay, yellow fever virus. Uh what class of viruses is this under? Flaviviruses, which are their DNA. Perfect. Single-stranded RNA. Good. Now, it's spherical and has an envelope. Okay, so that's how you remember how it looks like. I do not know if you need to know how it looks like. However, what you really need to know is these two. Can someone tell me what mosquito this is? Very, very important for the transmission of yellow fever. Hemophagus or whatever, however you pronounce it, not gonna lie. But yes, that's the most important mosquito in transmitting yellow fever. Now, this biopsy, where is it taken from? Liver, good. And what do you see in it? Councilman bodies, perfect. Councilman bodies are basically apoptotic hepatocytes, and they become big and become eosinophilic. It's not specific for yellow fever, I will tell you this. Other viruses can cause this, for example, hepatitis A, B even, I think. Most likely B, I think. But anyways, what I'm telling you is not specific. However, you will see it in yellow fever, okay? In your block, no yellow fever. Ignore what I just said. Anyways, it's yellow fever. So that's councilman bodies. Now, what is this one? Dengue fever. Good. Okay, dengue hemorrhagic fever, and it's transmitted by this mosquito. Remember the mosquito name. Description of what it looks like, not gonna lie, I am not too sure what it looks like very specifically. But basically, if someone has dengue fever, the more severe forms causes hemorrhagic fever, okay? Now, in hemorrhagic fever, one important key sign to tell you that this is a hemorrhagic fever is going to be retroorbital pain. It's a very important symptom seen in dengue hemorrhagic fever. It's very important. Muscle pain, bone pain, all these things are seen in dengue fever, okay? That's that. Now, for the next cases, I will tell you this. So, someone has neutropenia. Someone is immunocompromised. Tell me what this organism is, firstly. Pseudomonas. Good. This one. Tinobacter. Good. Now, if someone has cystic fibrosis, which one would I suspect? Pseudomonas. Good. If someone is in the ICU and gets an infection from out of these two, which one would I expect more? Actinobacter. Okay. This is from his transcript slides. I ripped it off from it. Okay. So yes, Actinobacter. Remember ICU? Pseudomonas is this. Now just to describe them. Actinobacter is a class of Pseudomonas. Okay, that's number one. It requires specific stains to stain this. Now, Pseudomonas, is it gram-negative or positive? Negative, good. And number two is it a rod or cocci or coccobacilli or what? Bacilli, and it's oxidase negative or positive? Positive. Okay, it's oxidase positive. So these are things to describe Pseudomonas, but anyways, they are infections that happens in immunocompromised patients. Pseudomonas is very important when we're thinking of cystic fibrosis patients. Actinobacter is important in ICU patients, okay? The last images in my lecture are these. Can you tell me what this one is? Candida, which are it's gram-positive, Candida, yeasts, okay? Molds are hyphae, so this exists as dimorphic, okay? Candida. What's this one? It's only mold. Aspergillus, okay? So these infections happens in immunocompromised patients. So for example, in Candida, it happens in diabetic patients, someone who's taking corticosteroids, immunocompromised, a lot of things. Aspergillus, same things also, but it happens in specific immunodeficiencies as well. And it has complications. So for example, it can mimic asthma and it causes something called allergic bronchopulmonary aspergillosis. In the lungs, it can cause these masses called aspergillomas, and it can cause something called angioinvasive aspergillosis, which basically it disseminates into the blood and goes everywhere. Okay, so these are the things. This is Giemsa stain, I believe, and it stains the hyphae, and then you can see the spores coming out of this conidiophore. I think is how you describe it. But anyways, immunodeficiencies, you think if it's fungal, you think of these two. And then you describe it based on the description. If it's a yeast and mold dimorphic, think Candida. Budding yeast cell, think Candida. Gram-positive cocci, think Candida, because it looks like it. Anyways, that's basically how to differentiate the two. Okay? And that is all from my review. Are there any questions? Is everything clear? Alhamdulillah. Of course. If you guys need anything, any questions you want to ask me, anything, my number, my email is in the beginning. Feel free to ask me anything. Good luck, inshallah, with the exam. I wish you all the best of luck, inshallah. Inshallah, it'll be easy. And yeah, thank you guys for attending.